In this presentation, I'm going to talk to you about how I as a physiotherapist look at chest x-rays. It's important to remember that a doctor can order an x-ray for multiple reasons. For example, to check the position of a line, or like the NG tube or central line. This means that the doctor who's reporting on the chest x-ray might not be looking for all the things that we are interested in as physiotherapists. I would always advise trying to look at the chest x-ray before you look at the report, and then check your findings against the report, remembering they may not have reported on everything. When you look at a chest x-ray, it's important to have a strategic approach and always check them the same way, and that way it avoids missing things or giving things more value than they may really deserve. For example, if you haven't checked the position or the exposure, you may think that there's a significant pathology which, in light of that positioning or exposure, might not be quite so severe or might not exist at all. So the first thing I look at is whether it's an AP or a PA. An AP film immediately tells me that this is a patient who is not well enough to go and stand in the radiography department and hold their arms above their head in the correct position for a PA film. The film is unlikely to be of good quality. The patient may be so unwell that they can't take a deep breath and hold it. The position of the patient, they might not be quite so square, there's more likely to be rotation. And also the heart in an AP will appear slightly larger than it does in a PA. You may note that I haven't talked about checking the patient's name and the patient's the date on the film itself. This is because with modern imaging, it is automatic that in our IT processes that they come up when we order them. Lists of systematic approaches that date back to when we had the films on printed copy, often those would get mixed up in the big envelopes on the wards, and often one patient might have 20 or more films over time, and so making sure you had the right one and the coding on that, and making sure that it hadn't been mixed up in another patient's envelope was a really critical first step. A first step which is no longer relevant today. So when I start to look at my film, the first thing that I'm looking at is I'm looking at the spinal cord, and I'm noting that it is nice and straight and central. I'm also noting the exposure of the film, and I should just about be able to make out the intervertebral discs behind the heart. There shouldn't be lots of detail. I shouldn't be able to see the transverse processes, for example. If I can see those, then the film is too black. If I can't see the discs at all, then it is too white. We can call that underexposed when it's too white, like your toast, it's not cooked enough. When it's too black, it's overexposed, like your toast, it's been overcooked and it's burnt. So this film is perfectly exposed. Where exposure really matters is when you're comparing a series of x-rays of the same patient to try to see if they're getting better or worse. And so it's really important to see whether a film is whiter or darker compared to the previous one in the series. Next, for position, so I've noticed the spine is nice and straight and central. Next, for position, I look at the clavicular heads, and these are here. And I look at them, there we are, and there, and there, and I look at them in relation to the spinous process. They should be equidistant from the spinous process, and this tells me whether or not the patient's rotated. Some people look at the whole of the length of the clavicle, but somebody could have had a trauma, or they could just have a shoulder raised through musculoskeletal, you know, malalignment or something, or habit or yeah, old trauma or something, which might actually not mean that they're rotated at all. So the clavicular head in this distance is considered to be much more reliable to look at the rotation. So that distance and this distance, in this case, they're very nice and equal. In an AP, it's very important to make sure that you've identified and sort of ruled out in your mind all of the other bony prominences. For example, in a PA, the scapula is likely to be in the way, and you just want to make sure that you know it's right out of the way. You just want to know what those are. Also, ladies' breasts can be quite large and sometimes can cause unusual shadowing, and so just again, good idea to make sure you've identified those. Alright, the next thing I do in my little list is that I count the ribs down. So I've always counted them from the lateral aspect. So I count this change here: 1, 2, 3, 4, 5, 6, 7, 8. So this person's actually a bit hyperinflated. Normally, so we've got 1, 2, 3, 4, 5, 6. So it is the sixth rib should bisect the hemidiaphragm, counting from this lateral aspect as it's coming around the front. And if I do it on the other side, 1, 2, 3, 4, 5, 6. We can even squeeze in 7 and 8. And I think, again, that's indicating this is somebody who's able to take a really big deep breath and hold it. In other patients, you might think it's a sign of hyperinflation, for example, in somebody who has COPD or asthma. The hemidiaphragms, you'll note that the right is slightly higher than the left. Now, some people say that this is because the liver is pushing up underneath the hemidiaphragm. I think if you've got the case of pregnancy or ascites or real large abdominal obesity, a really distended abdomen, it's certainly true that the diaphragm is unable to descend. However, the idea that the liver is pushing up on the diaphragm, I think that does need to be re-evaluated, because the liver is a really interesting organ, and when you cut a piece off of it, for example to do a transplant or something, then the lobe of the liver can often regenerate, and I think it just kind of fills the anatomical space that it's in, that it sits in under that hemidiaphragm. I think the more likely cause of the left hemidiaphragm being slightly lower is that you have this large organ, the heart, which is quite heavy when it's full of blood, and it sits on that left hemidiaphragm. But if we know all reasons why the hemidiaphragm might be raised, then we can consider it in context. It is possible to count the ribs from the spine, and if you did do it that way, it should be 10. The problem can be that quite often the top, you can get lost at the top, particularly if somebody's a bit kyphosed. Sometimes, particularly when somebody's unwell, the top of the film is missed off, but we'll try and do it that way for those who are interested. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. See, I think I must have missed one there. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. See, it's really, it gets a bit hard at the top. Know that there are both ways. So 1, 2, if I said that's 1, 2, 3, 4, 5, 7, 8, 9, 10, 11. I think that's probably more accurate. But you can see at the top here, it's really hard to count them and very easy to miss one. And when you get your what I call your eye in, and you get used to looking, I just find this a much easier way of counting down, and more reliable for me. Okay, so the next thing I look at is I look at, when I'm looking at the positions of the hemidiaphragm and counting the ribs down, I only look for bony deformities, like rib fractures and things like that. I only really look for those if there's been a history of trauma and I'm suspecting there could be a fracture. Otherwise, I don't tend to look. They can be hard to spot, but you're looking for a discontinuation in the line of the bone. So I only tend to look for those if there is actually a history of trauma and a reason why there might be a rib fracture. When I come down to the edge, I'm just looking to make sure this angle is nice and crisp and clear, the costophrenic angle, that the hemidiaphragm is lovely and crisp. I can see that border really well. This cardiophrenic angle is nice and crisp and clear, and the same on the other side. This hemidiaphragm is really crisp and clear. The cardiophrenic angle, and the costophrenic angle are both really clear. And the heart border is really crisp and clear too. I'm looking at the heart. I can see that there's a small bulge on the right side, and the majority of the heart sits to the left. If there is a shift of structures, then that could be clinically significant. So a small bulge on this side, you definitely shouldn't see, just like the spinal column. Small bulge on the right, and at least two-thirds on the left. Now the size of the heart should be 1/3 to 1/2 of the diameter of the chest. And what I do is I just put my fingers on, and I just see if I can say here and here, and then I move them across and see if they're the same size. So this here, the heart is less than 1/3, so that's perfect. The next thing I look at is I look at the trachea. And I'm looking to see it down to the bifurcation into the two main bronchi. I should only be able to follow it to the bifurcation into the two main bronchi. It should be nice and straight and central, not kinked to one side. And if I can follow it further, which actually in this normal film I can, I shouldn't be able to see that. If I can see it all the way down here, I don't know if you can see that I can actually outline it here and follow some of these main branches. That suggests that there's actually an area of hyperdense lung here that I can see that showing up behind. So that could be an indication of consolidation. The next thing I look at is I look at the lung markings, and I check that I can see them all the way to the edge. Now if you can see the texture here, this is where there is no lung markings versus the texture here. You can see the difference in the textures, and I'm looking to see that this texture extends all the way to the outside of the rib cage, all the way to the outside there. Okay, and next I look at the lung fields. Okay, and I'm just checking my way down, seeing if there's anything of significance. Now the things that we see that are significant is when we're thinking about physiotherapy, we're thinking about indications and contraindications. So I've gone through my strategy, my approach for how I look at a chest x-ray. Now I'm going to take that through onto some films with some abnormalities. So the first thing that a physiotherapist looks to treat is consolidation. And so what I did was I did a Google image search just of consolidation and chest x-rays. And these are some of the films that I was able to gain. So again, having a look at my strategic approach, what I can see is the spine is nice and straight and central. I can just about see the IVDs behind the heart. Maybe it is a little bit of a whiter film compared to the other one we've seen. I'm looking at the distance between the spinous process and the clavicular heads, and that looks fairly equidistant. So I'm not concerned that the patient's rotated. So anything, shift of structures that I might see, is due to pathology. It's not due to the patient's position. So I'm now counting the ribs down, and I'm counting 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7. Lovely. And so the 7th ribs are bisecting the hemidiaphragm, so there's no collapse of the bases. The angle here is nice and crisp and clear. The hemidiaphragm isn't too bad either, but this angle is really quite messy. It's not clear. It's much less distinct. Okay, and on the other side, it's nice and crisp and clear. The hemidiaphragm looks good. It's a little bit less distinct here, but not so much as on the other side. And that heart border looks fairly crisp. The heart, there's a nice bulge on the right, majority of it is on the left, so it's in a normal position. And the size of it, it looks to be about a half to me, so that looks good. I'm now looking at the trachea, and I can follow the trachea down its central to the bifurcation to the two main bronchi, but I can't follow it quite a way down. And again, on this side, I can actually follow it quite a way down here too. So that tells me that these lungs, maybe there's some fibrosis. It actually goes down to all the way down here. So maybe there's some fibrosis of these main airways. There's certainly the lung is more dense, and the air is showing up in those airways more than they normally would do. I'm now looking at checking to see the lung markings all the way to the edge. And yes, no concerns there. That means there's no pneumothorax. However, I have noticed as I'm looking at the lung fields, this line, and I'm intrigued by that. It's certainly not an indication of consolidation. So it's perhaps just another interesting finding on this film that's been posted on Radiopedia. But I wonder if it might be indicating some fibrosis or some fluid, and this would perhaps be in the fissure, the joins between the different segments of the lungs. And that's just standing out a little bit thicker than I might have expected it. I wouldn't normally expect to be able to see that. It doesn't align with any other anatomy that I can think of, other than the separation between the different lobes, segments of the upper lobe of the lung. So perhaps there's something brewing up here. Looking down, this is increased lung markings. And so these increased lung markings indicate consolidation. That in conjunction with this, that could be called an air bronchogram, when you can follow the trachea further than the bifurcation to the two main bronchi. That's an air bronchogram. And those might make me think that, that there's some lung pathology, perhaps some consolidation. The location of that consolidation, if I had to pick for postural drainage or for positioning for somebody for VQ. I don't think this is in the bases of the lungs, because these hemidiaphragms, this angle looks pretty clear. I would say this is more in the middle zone of the lungs, middle lobe, on the right middle lobe consolidation, and that's what I would mainly pick to treat. I would be aware that there might be something sort of in the left lingula or the top of the left lower lobe also going on. So in this film, again, I can see the spinal column is nice and straight and central. There's quite a crisp detail here. So you might actually think that this film was relatively dark, which is interesting because we can see quite a lot of lung markings here. So this film is relatively overexposed. It's relatively dark just because of the amount of detailing that we can see here, although still pretty good. This is the spinous process, and I'm looking at the distance, and there might be a little bit of rotation here. I feel like this one is just a little bit closer to the spinous process than this one, so there might be a little bit of rotation, although not a huge amount. Counting the ribs, 1, 2, 3, 4, 5, 6, 7. Again, we've got a slightly inflated set of lungs here. 1, 2, 3, 4, 5, 6, 7. Perhaps somebody able to take a really good deep breath and hold it. Maybe they've been a singer or something. So now I'm looking at this angle and it's nice and crisp, beautifully crisp hemidiaphragm there, nice and crisp. On this side, not so much. It's looking a little bit less crisp than that side. Not too bad in this lower lobe. The heart, you've got a bulge on this side, majority of on that side. The size of it's probably about a half, and that's okay. This is less distinct, and this is not too bad through here, but there's certainly something going on maybe through there. I'm looking at the trachea. It's nice and straight and central. I can see it down to the bifurcation to the two main bronchi. I can't really follow it further on this side, but on this side I'm following it. I am following it further, and I'm checking the lung markings, and I can see them all the way to the edge and all the way to the edge. So consolidation in this Google image, I would probably, just because of this air bronchogram, I probably predominantly treat that sort of left lingular type area, just because of this stretching all the way out here. I think that's probably my area of a little bit of consolidation in there. The lung markings do look increased throughout, so maybe there's some inflammatory exudate on top. This X-ray was posted as an example of consolidation, and this is where I would pick it primarily to be. Possibly a bit in the right mid-zone as well, though. On this chest X-ray, okay, this is an example of atelectasis or collapse. When you think about how you describe things to patients, just throwing this in there, probably the worst thing that you could tell a patient is that their lung has collapsed. It brings up all sorts of images for patients of things inside their lungs that aren't necessarily helpful. I think what's more useful is to describe it as being deflated, like a balloon. Your lungs are deflated and we need to reinflate them. It's a less alarming way of putting it, and something that they can easily understand. Okay, so now having a look through this X-ray, which is a bit different from some of the others that we've seen, we can still look at the patient's position, but you can see that it's actually become really hard to see where the spinal column is. We can still see the spinous process in there, and we can still see the clavicular heads, but this one's all the way over here, and this one's right up here. So actually there's quite a significant element of rotation, and that's going to make interpreting this X-ray much more challenging, because it's going to cause some shift of structures. The other thing that you'll note is the spinal column is really hard to spot, and you can't see the intervertebral disc. So this suggests that this X-ray is more white, more underexposed than most. So the other thing you see quite a lot of lines here. This patient is a more sick patient. This would be an AP film. This is likely to be, this patient is intubated and ventilated. These are likely to be monitoring lines, ECG lines, and this looks like it's a chest drain. Okay, so we know something about the patient already. It's an apical chest drain to the top. So at some stage this patient had a pneumothorax. I think these dots here are likely to be external equipment, a mask of some description, something like that. This could be air in the tissues. This wasn't something that was identified. It wasn't identified for in the Radiopedia page, but that might be something of interest. There might be a little bit associated with this pneumothorax, the reason for this chest drain. There might be a little bit of subcutaneous emphysema. I'll show you a better example of that later on. So the next thing, so I've had a look at my patient's position. I've noted that it's quite a white film. I've noticed that the patient is quite rotated. I'm just going to see how the ribs count down. 1, 2, 3, 4, 5. That's the 6. But it's hard to see where that hemidiaphragm actually comes in, isn't it? It's really hard to see that. If I look on this side, 1, 2, 3, 4, 5, 6. That's a beautiful, bisects the hemidiaphragm nicely. This is nice and crisp and clear. Whereas on this side it is not, it's hard to position. The heart, you'll note there's more on this side and less on this side, so the heart is potentially shifted across. So you've potentially got a raised hemidiaphragm and the heart shifted across. Now that might suggest that you've got somebody who's got an atelectasis or collapse on the right hand side. In conjunction with this, it might make you think, oh, was there some kind of a tension pneumothorax that kind of pushed everything off to the side and everything hasn't re-inflated again yet? And is this a massive atelectasis down here? Some of that does have to be taken with a pinch of salt because of this rotational element. It's hard to know how that's affected the shift of structures. The trachea is fairly, you can see that's the bifurcation to the two main bronchi. Sometimes it helps to sort of look at things from a different angle, but that's the triangle of the two, and so it goes down to there and it's coming down here, and I'm not seeing anything particularly abnormal there. Looking at the rest of the lung markings, they're coming. I'm just wondering about if there's a little bit of a pneumothorax left up here. Lung markings, can definitely see them to there, but then perhaps I lose them, so there might be a little bit of a small pneumothorax up the top. Still, there is some slightly interesting sort of texture to these lung markings. It's a little bit gritty, which sometimes, you might call that ground glass. So I'd be keeping an eye out for that. If somebody, that occurs sometimes if somebody's got a sort of fibrotic, fibrosing alveolitis, something like that type picture, or sometimes it comes with things like ARDS, ARDS. It's this sort of gritty texture to it. It's less, like up here, it's more kind of like fluffy. Whereas this sort of looks a bit gritty, but at the same time that doesn't really fit with the rest of the film. So I'd be keeping an eye out on what's going with their oxygen levels, what's, if they've got other organs in trouble, what their area pressure's doing, and so on, because this is a person who's ventilated. But the overriding feature of this film for a physiotherapist is that you've perhaps got collapse of this side that we need to reinflate. So my treatment would really be focused on reinflating that. Once we've got the chest drains in, they're fixing hopefully the cause of the shift of, like, if there was an tension pneumothorax, they're shifting that, and then our work is on trying to get that area of lung that's collapsed reinflated. Okay, so this is another film looking at atelectasis collapse. So again, checking the spinal column, is it nice and straight and central? And it's, again, we lose sight of it here. It looks like it's probably fairly straight, fairly central, but this is a whiter film. We can't see the intervertebral disc behind the heart. The spinous process and the clavicular head. And there's a little bit of rotation, but less, I think, than in the previous film. Okay, counting the ribs down, 1, 2, 3, 4, 5, 6, 7. So nicely inflated. 1, 2, 3, 4, 5, 6, 7. Like the hemidiaphragms are in the right places. This one's a little bit more opaque. I do notice this may be a larger person, some quite larger breasts, which might influence if it's on both sides, you know, just the opacity in the bottoms. But definitely there's something going on here, isn't there? It's making that hemidiaphragm. You lose it's lost its distinction there. And again, the heart border, it's lost distinction there. On this side, it looks a bit clearer. Again, still loss of distinction in that angle, and I think that's probably, yeah, I think that must be a body habitus thing more than anything else. Just the way that it's slightly whiter and whiter and whiter as you go down. It's not, that's how it makes me feel when I'm looking at that. The next thing I look at is that the heart, and that's a little bit sort of 50-50, isn't it? It's not too much, but maybe a little bit more off to the right than I might have expected. And it's about the right size. The next thing I look at the trachea, and I'm going, oh, what's this trachea doing over here? Look at that. Yeah, can you follow that? And the bifurcation into two main bronchi is here, and then we lose it. So this is the tracheal deviation to the right, and this is a sign, and that in conjunction with this makes me feel like there's a shift of structures to the right, and we've got potential consolidation collapse, probably of the middle lobe on the right. Classically, if you're talking shift of structures, the upper lobe, middle lobes would cause like tracheal or cardiac deviation. The hemidiaphragms more when it's sort of like the lower lobes and so on. Then you get shift of those structures. So this looks to me like a consolidation collapse of the right middle zone. Okay, so the other reason we look at x-rays is we're looking for indications, reasons to treat. So those reasons are always, to do what physios can treat is consolidation and collapse. The other things we look for is contraindications. So it's really important to be able to recognise those. Now, if we look at this film, we can see the spinal cord is nice and straight and central, the intervertebral discs behind the heart. Counting the ribs down, 1, 2, 3, 4, 5, 6, 7. It's the high hemidiaphragm. Oh, that looks nice and crisp, doesn't it? On this side, 1, 2, 3, 4, 5, 6. Less crisp on this side, and we've lost it at the bottom. Now we look at the heart, and it's a bit less clear, but we're seeing some on this side and some on, but the majority on the left, and it's about the same, half the diameter of the lungs. Now the next thing to remember I look at is lung markings all the way to the edge, and if you look at this bit here, and its similarity to this bit here, compared to this bit here. So the lung markings, I'm following them to the edge, and I come to here, and there's no lung markings beyond. So I can follow lung markings all the way to the edge here, and there's no lung markings beyond. So this is a pneumothorax. It could have become a tension pneumothorax, in that I wonder if there's a bit of pressure coming across. The heart might be a bit squished across. Things are quite collapsed, aren't they? Maybe this hyperdensity is because there's pressure coming across and it's all getting a bit squashed. This is pneumothorax. As physios, we can't treat this, and indeed if we were to treat a patient with a positive pressure device, then we could make this substantially worse. So it's really important, if we see a pneumothorax, we don't use any IPPB, CPAP, PEP, or anything that could cause positive pressure until, or at least unless there's been a drain put in and the drain is working. The next film. Okay, so this isn't a perfect example of this contraindication, but I'll show you what it shows anyway. So just because it's just such an extreme example, yeah, it's rare that you would see one like this. So again, spine is central. There's a little bit of rotation. 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4, 5, 6, 7, and so this is maybe slightly hyperinflated, this set of lungs. Trying to work out where the hemidiaphragm is, it's not easy. On this side, it is much easier. There is a bit. This is tenting when you've got this peak, and that suggests that there's sort of chronic fibrosis or something that's caused fibrosis and the things sticking together, so it's not all nice and smooth. So that's tenting of the hemidiaphragm. Okay. The next thing I'm noticing, so the heart is about the right size and it's in about the right position. You notice I'm deliberately not going to the big thing on the big impactful thing we can all see yet, because it's really important to make sure you just take everything on board on a film and don't deviate from that. So the trachea, straight and central, it perhaps is a bit deviated off to the left, and now I'm looking for those lung markings, and I can quite clearly see the lung markings are not normal. We can see this all the way to here, and there's lung markings all the way to here. This is probably the horizontal fissure, it might be, or actually, that's not the right place for the horizontal fissure, it should be in here. So there's something strange going on in this film. I wonder if some of you know what it is. So again, we're looking for contraindications, and another contraindication is emphysematous bully. And what you have here is a massive, absolutely massive bulla. We have other ones, so we have another one up here. Perhaps that's another one in there. So the lung around and between the bulla gets, could be quite normal, but it gets squashed as the bulla just fills more and more of the space. So we have some massive bullae on this side of the lung, completely making it so that that right lung around that has completely gotten squashed and is not being of any benefit at all. On this side, there could actually be some other bullae, and the lung in here, you can see those. This is much more how sort of often it can appear like this, so these black darkened patches. So this is what you're more often looking at, this patch here. But here we've got one massive bullae popped, but it's not caused a pneumothorax, but the risk is that it definitely could do. So again, I wouldn't use any positive pressure techniques. Oh, I think there's another one up here, look. Can we see that there's this sort of thickened area around a darker one. So I think we can, oh, and more in here, look. Can you see that? Thickened around these dark. So yeah, bully, we don't use any positive pressure devices because we don't want to pop a pneumothorax. If it was really like last line do or die stuff, then you know, we might, but we would definitely discuss it with the doctors and have them ready to be prepared to drain that pneumothorax if we caused one. So it is again a relative contraindication and not something that you should do routinely. Okay, next film. So this film's really interesting. I'm just going to I'm not going to go through. I mean, this is quite an overexposed film. You can see all that detail and the lipping and everything. So you can see it's a really black film. That's not why it's in. I've picked it. I've picked it because this is an example of subcutaneous emphysema. I've seen this quite a few times in my career. Often it's associated with trauma or pneumothorax, so fractured ribs, pneumothorax, chest drain. And what this is air has leaked out and it's in the tissues. So you can see the fibres of pec major as they come in across the chest. You can see all the air in here. You can see all the air up into the neck and the scalenii and stuff. And somebody can be just full of surgical emphysema. It can be quite painful, not always, but it can be really, really painful depending on how tense it is. It can fill somebody's, right up into somebody's eyes and really be very deforming. So this means that there's a leak somewhere. So again, I wouldn't be doing a load of positive pressure techniques. I also, there's no point in auscultating this patient because you're just going to hear, if you put your stethoscope over those tissues, all the air will sort of like Rice Krispies, it will like pop, 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 and I mean, if you keep pressing, ultimately the air will sort of move out from under this stethoscope and you might be able to hear something, but it's not very comfortable and really what we're trying to achieve. But you can feel it when you touch somebody, you can feel the air under their skin popping. It would be very painful. You're not going to do any manual techniques or anything like that on somebody who has surgical or subcutaneous emphysema. This film is, again, if we just do it, so this is somebody who's maybe got a little bit twisted, a little bit rotated, maybe they've got a little bit of a scoliosis. Spinous process, the clavicular head in there, clavicular head there. You see how sometimes I have to follow it down? Yeah, sometimes it's just really obvious and sometimes you have to follow it. So they're pretty, not too much rotation. Counting the ribs, 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Cool. This is a little bit of tenting, a little bit of tension tether points. You can see that. Might be a little bit of fluid in the bottom there. This is very tented, isn't it? That's the diaphragm. This is fluid and air in the stomach. The heart. So this is relatively crisp and clear. The heart, it's a little bit of a bigger heart, although actually, no, when I look closer, it's only a half. Again, right positioning. The trachea down to the two main bronchus, yep, no problem, and it's fairly central. Maybe a little bit kinky, but then we were saying the same only follows the track really of the spinal column, so I'm not too worried. So looking down here, I can see there's something going on here. And there's something here. Okay, the rest of this doesn't look too bad, and this looks too bad. And what's going on here is you've got lung cancer that's caused the air can no longer get into the upper lobe. It's occluding the upper lobe bronchus, and so the air isn't really getting into that upper lobe. So you've got consolidation collapse of the right upper lobe, but you've got a lung cancer there that's causing it. So yep, we can get them up and moving, yep, we can do breathing exercises, but there's potential there for air trapping. So we wouldn't want to be doing any positive pressure device that's going to force air into their lungs, because it could force past it and then trap and not allow it to come back out. So that would be contraindicated. And you wouldn't want to do a load of manual techniques on somebody with cancer either. So I thought I would show you some films of the new COVID-19, some of the ones that have been published. This is what we're seeing, what they're saying. They're saying, so this patient has a nice, again, nice and straight and central, the clavicular heads. Perhaps they were a little bit rotated when they took this film. Counting the ribs down, 1, 2, 3, 4, 5, 6. So maybe not a full inspiratory film. 1, 2, 3, 4, 5, 6. Or maybe a little bit of slightly raised hemidiaphragm on the right. And that kind of fits with some of the other features that we're seeing. So this is the heart. So this is quite a, so it's about half. It's not clear whether or not this is an AP or a PA from what I've been able to retrieve. I suspect it might be an AP, just on the basis that this patient's likely to have been breathless, yeah, I just wonder if it's more likely to be an AP. Next thing I'm looking at, and just on the basis of the size of the heart as well, so the next thing I'm looking at is the trachea. It's nice and straight and central down to the bifurcation to the two main bronchi. And then I'm looking at my lung markings, and I can see them all the way to the edge, but I can see this slightly increased area here, and this side looks fine. And I would say that this person is in the stage where they've got some pneumonia due to COVID, and so you've got thickening of these airways, and perhaps some atelectasis. They've perhaps squashed down a bit as well. So you've got thickening of this area of the lungs. So my treatment, if they were, I wouldn't treat them if they were unproductive, but if they were productive, I would focus my treatment on the right upper middle, the top of the right lower lobe or the middle lobe, and I'd have that would be where I'd focus my treatment on, if they were productive. Of course, if they were unproductive and they were mobile, then we wouldn't be doing anything for them with physiotherapy. This next film is a patient who has COVID-19 who's gone on to develop ARDS. This is typical that, you know, in ICU it's really hard to get, sometimes to get really good films, like getting the board under the patient in the right angle and so on can be really difficult. And so we've got somebody who's not in an optimal position. We can't actually see their clavicles at all. But what we can see is this picture of ARDS, which is where we've got bilateral infiltrate throughout the whole lungs, increased lung markings everywhere. This is the trachea down to the bifurcation to the two main bronchi. The hemidiaphragm here looks, I mean, I can't count the ribs down, but potentially that's quite raised just from the shape of it. But that could just be the angle at which, and from the ribs as well, the angle at which the film has been shot. But what's to take away, the takeaway point here is this: there's this inflammatory exudate that fills the interstitium between the cells in the lungs, and just floods throughout the whole of the lungs. And so anything that's like that is something that physiotherapy can't necessarily treat in and of itself, that interstitial process. So what physiotherapy can do is we can help positioning for VQ, like help assisting with prone lying and things like that, and ventilation perfusion, VQ. So we could prone lie, and the other thing we can do is, should they be productive, and there's some patients are now being I understand, have been found to have very thick, sticky secretions, and because they're on higher levels of sedation and paralysis than we would usually use on a lot of patients in ICU, then their ability to cough to a suction catheter, there's no cough reflex, so they need sometimes manual techniques to try to get the secretions to where they can then be suctioned up. So potentially a physiotherapy role in that. But an ARDS type picture, just a pure ARDS picture of inflammation, or an interstitial picture where, say, pulmonary edema, that's not something that physiotherapy can usually have a positive effect on. So these patients are presenting slightly differently, is my understanding. I hope you found that helpful. I will have a quick look on Slack and see if there's some other good pictures I can show you. So not Slack, I apologise, that's the chat group. This is best a resource called Slice, and it's a huge library of images. So what I've done is I've just typed in consolidation, and we can just have a look at a few of those films that are particularly, so this is the consolidated area here. We can have a quick look at some of the best of their resources. What other ones are particularly good? So this one, obviously this isn't a consolidation affecting the whole of the left lung. It's less usual to see that. This is quite a severe pneumonia, I would suggest. This is quite a nice one because it really shows that's the horizontal fissure, and the consolidation is really focused in that upper section of the lower lobe, or the middle zone. Here I've just put in atelectasis, and I think that's our similar X-ray to we saw before, isn't it, with the cancer and then atelectasis behind it. This one, you've got this sort of wedge shape here, where things have kind of got squashed. Can you see how sometimes the breasts cause a little bit of a confusion? Although, yeah, this line is slightly, it's hard to see what's what really. And that's why sometimes, you know, X-rays are a three-dimensional thing that's been squashed into two dimensions, and I've also found that they lag a little bit sometimes behind, they might lag a little bit behind, you know, the clinical picture. Sometimes things don't show up on X-ray that you kind of like, you've almost seen in the signs and symptoms and the rest of their clinical picture beforehand. So I always back up what I'm thinking that an X-ray shows me with auscultation and with the rest of the clinical picture. It's just one imperfect tool in our armoury, but it can be really useful. So these are other images of some atelectasis caused by various things, I think. This one is quite interesting that they're calling it atelectasis, in that this to me looks like it's quite a widened mediastinum, and I wonder if there's some fluid in there, and there's some kind of an interesting effusion that's then causing some atelectasis. Don't worry too much about the laterals. Definitely get your head around the just the standard X-rays first. Yeah, would be my primary thing. And this is what I really brought you here for, is just some examples of your contraindications and cautions that are the thing that you really need to be able to spot. And so this is a whole bunch of pneumothoraces, so you can see lung markings to here, and there's no lung markings at the top. On this one, there's lung markings to kind of, there's the lung, and then it kind of comes in here, so there's no lung markings on the outside here. Here, And this is, yes, I'm skipping, but my eyes, I'm pretty used to looking at these things, so that's why I'm doing it. And like I say, when I see a new X-ray and I haven't Google image something, I always go through my strategic approach. It's just I'm playing spot the pneumothorax here. Big pneumothorax here, potentially even a little bit of one on that side there. Here, there's pneumothorax, there's the edge of the lung. Here's a massive pneumothorax, tiny little kidney of a lung, it looks like, almost. So pneumothoraxes can be big and small. If they're just filling the top, tiny bit of the top, then the doctors may choose not to drain them, and they might just let them recover if the patient's not too symptomatic. But if they're really big and causing pressure, then they would need to definitely put some chest drain in and do some definitive treatment. And that's their decision, but the important thing is, as long as there's a pneumothorax and as long as it's undrained, that's a contraindication to many techniques. This is probably the best film that we have of bully. You can see that one there, and there, and there, and there's another one in here. So this is some bully. Over on this one, you've got a bit of a pleural effusion on here, over here. I'll just see if I can pull that one up. I won't be able to see that so much. It's just off the side of my screen. So yeah, so I'd say that's a bit of a pleural effusion, but there's some bully in there too. Some bully in there. Yeah. So yeah, that pleural effusion needs draining, but we'd be limited to what treatment we could do because of these bully. Another thing you guys might have heard of as being a contraindication to treatment is TB. Just as a note of point, I was told when I was training many moons ago that I wouldn't see TB in my career, but that's definitely not been the case. The TB flourishes when there's poverty, and you know, with HIV and things and that coming from Africa and so on, and poverty in certain communities, it can be quite, it can take quite a hold. And I think also if the anti-vax movement continues, we may well see more of it. So TB kind of presents as sort of these dots, and the reason why that's a contraindication or theoretical contraindication to treatment is that potentially they think that the spots that remain on the lungs can like be cyst forming, like they form a little cyst with all the bugs inside them, and then if we used aggressive manual techniques or things like flutter and things like that, then potentially we could rupture one of those. The theory goes that we could rupture one of those little sacs and spread it and cause, you know, more widespread pulmonary or indeed miliary TB. So TB has always been considered to be a relative contraindication to manual techniques or vibratory techniques. The other thing is that we don't do aggressive physio on is lung cancer. So here we have, this is sort of the classic picture really. If you've got any sort of organised ball somewhere in the lungs that it shouldn't be, then be suspicious. It doesn't necessarily mean, you know, we don't know. But given that the literature says that no one type of chest physio is any more efficient than another, we know that ACBT, osteogenic drainage, breathing exercises, getting people mobilising won't do them any harm, whereas you could potentially cause gas trapping, or some people talk about, you know, potentially you could cause spread. I don't know that anybody's proven that, but given that the literature doesn't support any one kind of chest physio over another, then always err on the side of caution, so I wouldn't use those techniques in somebody who had anything on their chest X-ray that maybe looked a bit like that. I would just err on the side of caution. Yeah. I hope that's been a useful summary of how I think about and use chest X-rays. My greatest advice probably would be to conduct, to get your eye in, look at every chest X-ray you can. The more normals you see, the more likely you are to pick up something that's abnormal. Do chat to the MDT about it. Don't be frightened to ask a doctor what they see. Often they're really pleased to have a chat. Like I say, sometimes they're looking at chest X-rays just to see this line of just to see where a line is or something. They might not have picked up things that, or might not have looked for things that we look for. So always a good idea to have a chat with them about what you've seen, and just get that confirmation. But also to get your eye in, the best way of doing it is Google image searches and things like Radiopedia. And if you're a student or of the university, potentially you can get on this new website, this BEST website, and have a look at the images on Slice.